is now open to discussion. So we have 6 panels. Dr. Do-yeon Kim and Hong Seok-bom are cardiac surgeons. And then Kim Eun-kyung is echo specialist, Son Bong-yeon and Byung Yoo-hwan. Please feel free to raise question and comment. So I'd like to ask you, Dr. Paolo. So, sometimes we met the case, we failed make a coaxiality of sapien valve to the surgical failed valve. So in this case, it's very difficult to make coaxiality. How do you solve this problem when deploying the valve?
Yes, it's a good question. Most of the times, so the case I showed was in a mosaic valve where it's very important to be coaxial, or at least if you cannot be coaxial, you have to start a little bit more atrial. So the good thing is about mitral valve valve is that even if you don't start coaxial, in the end, during the inflation, the valve will self-center because you have a long stent of the surgical prosthesis and the balloon will realign the valve as you go with the inflation of the balloon. It's different when you do valve in ring or valve in MAC. In native valve, this is a problem because if you don't start coaxial, you do not land coaxial. So for those cases, then some tips and tricks that we can use is the push-push technique. So you push the wire a little bit and you push the delivery system on the other side. This will make the system pivot a little bit and increase the coaxiality of the device. But you cannot push the wire too much into the apex or you can risk a perforation. So you can push, but with being gentle. Another technique that you can use sometimes, you can have the delivery, if you have the commander delivery system inside the left atrium and you flex the catheter and you posterior torque the device, then you create a different trajectory of the balloon catheter that is going to be more coaxial in the anterior-posterior direction. So there's some limited maneuvers that you can do to make it better. But most of the times involving valve, as I said, is not so critical.
So in the United States, in doing transmitral valve valve, the cerebral protection is routinely done or in selected cases?
It's not, I think we don't see more use of embolic protection devices in mitral procedure because there's no evidence of an increased risk of stroke. So centers that they use embolic protection devices for TAVI, they will also use it for mitral, but not necessarily. I have to tell you that in most of the centers, mitral valve has become a full venous procedure. So, because of that, if you are an experienced center, you don't perceive there's a higher risk of stroke. You just do a simple venous procedure with single transfemoral venous access, even pacing through the wire, not even using a temporary pacemaker, and that shortened the procedure dramatically. Now, if you are planning for arterial access and then you are very confident and comfortable with the use of embolic protection devices, it's fine, it's okay. But we are not seeing an increased risk of stroke.
Dr. Paolo, how do you manage the ASD, balloon-made ASD, artificial ASD? Do nothing or closure in your clinical practice in the United States?
Yeah, it's a good question. I can share with you that looking at the TVT registry data, only 7% of the patients receive a septal occluder after mitral valve valve.
Which case?
And I can tell you that that 7% is driven mostly by some centers that they close every single case. There are centers that almost never close, other centers always close, and then in summary, we have a 7%. Personally, I believe that we should close every single case where you have a right to left shunt, or if you have a very severe shunt with RV dysfunction, and the volume overload is hurting the right ventricle. In those cases, I think it's prudent to close the AST.
Mm-hmm. Okay, I have a question for Dr. Huang. Byung Hwang. You showed a very interesting clinical study data about the valve in mitral valve in valve and valve in ring and valve in mag. So you showed the valve in valve was much better than valve in ring and valve in mag in terms of clinical outcome, especially mortality. We know very well valve in mag usually associated to high pressure-related death because of embolization risk very high. But why did the valve in ring show the bad clinical outcome similar to valve in mag?
Actually, I have only had cases in mitral valve and valve. I have no cases in ring or mag. But
okay.
So I'm not a cardiac surgeon, but I think that the valve is more resistant and more rigid than the ring. I think ring is very soft, so it has more PVL and something like that. So I think that is the difference between the valve and the ring.
Okay, second question. You showed very wonderful cases, simultaneous TAVI and mitral valve cases in patients with severe aortic stenosis and severe MR. But I think that that kinds of simultaneous procedure usually associated with a higher complication rate. And second is, if you treat severe AS with TAVI, you can evaluate properly MR severity. I think that if you treat a severe AS, MR severity would be decreased, and you can avoid unnecessary procedure, the mitral valve and valve procedure. What do you think about that?
Oh, I think very excellent question. Actually, we did the procedure with the TEE guided. So after putting the LT valve, we checked, and there was severe MR, so we went to the second valve. And in the worldwide data, so there are some debates about doing it simultaneously or next time. Mm-hmm. But there are debates, but the results is not that different from simultaneous and doing it late. So we did it simultaneously due to patient's conditions like that.
So I'd like to ask you, Dr. In. So in cases applying the occluder of the mitral PVL, so did you experience further tearing of surrounding tissue and require more the plugging?
Yes, we do. In the very beginning of our attempts, we use such as the septal defect occluder, I mean the muscular VSD occluder, which has a very strong radial force. So in that case, after we deploy successfully, but 1 or 2 weeks later, it outstretching the surrounding tissue and make a new relief. So we have to fix it up the second time. Mm. So afterward, in Taiwan nowadays, we just use ADO2 for the smaller leaks, and the VP2, which is have a very fine mesh and the soft, and can conform to the defect to see the large defect. So that's the current practice of our center.
So in your slide, you showed the beautiful the simultaneous application of two occluder in large PBL, but you did not show the sequential application of the occluder. So in cases of sequential application of one occluder and then next occluder, any partial tips?
We don't like that at all. Because the second delivery system may interfere or interact with the first occluder, which may have some dislodgement or migration of the first one. So we usually do simultaneous deployment. And that's easy, because if you can push one caster delivery system across the lesion, you can push two extra support wire and then two delivery caster. Then you can deliver the two occluder simultaneously. And as we shown in the type 1 PBL case, we use one large ball delivery system to deploy two small ADO2 occluder. It can be done easily too. So I strongly suggest that if you want to do more than one occluder, you do it simultaneous. That would be better.
Yeah. Doctor? Okay.
Yeah. I'm Ju Young-an from Samsung Medical Center, Seoul, Korea. I have one question to Dr. Ying. One of the difficulty during closure of PVL is determination of proper size of.
Then the sound is too low. I cannot hear very clear.
Okay.
다시 해주세요.
요 앞에 마이크.
요 앞에 마이크. 크게 해달래요.
One of the difficulty during closure of a paravalvular leak is determination of appropriate size of occluder. I'm a little bit concerned about embolization of occluder, so I prefer relatively large size of occluder, 10, for example, 10. So do you can you explain any practical tip for determination of size of occluder?
Usually we measure the width of the lesion and choose a disc 1.5 times larger than that width. That can guarantee the not to embolize the lesion during deployment. If you have a long lesion, you'd better to prepare two occluders or three occluders in a row. As I said, two or three smaller occluder would be better than one large one. Because the large one, you still have two small defects on either side. So that may not be fill the gap securely and thoroughly. So I strongly recommend, if you want to do a long lesion or big gap, you just use two occluder instead of one.
Yeah, in the panels there are cardiac surgeons. Dr. Do-yeon Kim, did you experience the fixing the mitral PVL by surgically? In surgical case, did you feel? Did you touch the tissue of the PVL? And then, so as a surgeon, do you have any opinion or positions in transcatheter mitral PVL closure?
I haven't no much experience of the PBL closure, so do you have any another? Yeah.
If the PBL is caused by annular disruption or the broken of the prosthetic replicate, it cannot be treated by the simple method. It should be treated by the redo mitral valve replacement. But in case of the the PBL comes from the local dehiscence from the broken suture material. It can be treated by the simple suture method.
Doctor, you come here.
As a cardiac surgeon, even when we open the field and just look at the mitral valve PBL, it's very difficult to decide whether I have to replace it or just repair it, because most of the PVL case, it starts with small crack, but the crack is extending almost. In some patients, even half of the annulus is involved with a crack. So I prefer to replace it. But I wonder how cardiologists can decide just with the preoperative CT scan or echocardiogram. How can you decide whether?
Yeah, it depends on the stability of the prosthesis. Actually, if the valve is already dehiscent and rocket in motion, then a surgery is to be done. But if it is not, still not that much rocket in motion, then we can try maybe 2 occluders using the disc to fix the surrounding tissue.
So
hoping
rocking
that
motion
they
is
can
the
stabilize
most important
the movement.
key. Rocking motion is the most important key for your
Yes.
decision.
Yes, yes.
In Korea, we, as far as I know, only vascular plug 2 is available in Korea. Its shape is round and it has
That's compatible.
radial force, so it can make the crack wider after the procedure. I'm always worried about that.
The radial force of VP2 is not so large, so it's okay. It's a very soft mesh, so you can use that in large crack, no problem.
Yeah, in Korea, the PBL closure occluder used in Taiwan are not available in Korea. That's the Korean situation. So we cannot fix PBL easily, as Dr. In performed. So anyway, there were a lot of the active and lively discussion, and we thank for 3 excellent lecture speakers, and we have to close this part 1 of this session. So thank you, Dr. In and Dr. Paula.
Thank you.
Thank you.
Hello.